I think that question is answered very simply by this cancer patient. I think the patient should be told the truth. Time is so valuable, and there may be things she wants to accomplish. There are decisions to be made. I can never forget the young 30-year-old cancer patient who walked into my office, and she said, "Am I going to die?" We had operated on her a week ago for a twisted ovarian tumor in an emergency. It turned out to be a metastasis from an advanced stomach cancer. And she walked in and said, "Am I going to die?" And I prevaricated and I said, "We're going to give you chemotherapy. Let's see what happens." And she says, "No, am I going to die? I have very young children. I want to know. I need to make the decision myself who is going to look after them after I go." So the question is not should she be told. She has to be told. But how do I tell her and her near ones? That which hurts most in the delivery of bad news is not what we say, but the manner in which we say it. This sounds very simple, but this is greatly underestimated by our medical fraternity. It can make all the difference to whether a patient and family can cope in the last few months. If we just tell them in a very blunt, offhand way, "Well, this is the end, we can't do anything more. Come back to us if you need to, otherwise there's nothing more I can do," they go back in a state of utter confusion and havoc, which can ruin the last few months of their life. The first dictum is always tell the truth. If the patient finds out that we're being untruthful to her, she's going to lose confidence. And later on, even if we're telling her the true facts, she's not going to believe us. And honesty creates a bond, which is very, very important for the terminally ill patient. It adds greatly to her comfort levels if she knows that her physician is honest and overboard about everything with her. And we see this on a daily basis. When we've been overboard and honest with a patient, spoken to her about her disease, spoken to her spouse, every time she comes back for follow-up, she's going to seek you out amongst all the doctors. She wants 5 minutes of your time. She relies on that 5 minutes, and that is what carries her through to a great extent. So always tell the truth, but not always the bitter truth, as our Hindu proverb says. The human mind is something fantastic. It can take in only as much as it can at a time. So if we break the news of a terminal illness and then we go on in the same session to speak about survival rates and metastasis and nodes and statistics, it's not going to go into her mind, and she doesn't want to know the bitter truth at that time. It may take several sessions. We have to listen to her before talking. We have to know how much she knows already, how much she wants to know at that time. Never, never blurt out what she's not ready to receive. Don't talk when we are in a hurry. We must never do that. We have to break the news and then let the patient absorb it and let her ask questions which she's bound to want to ask you. And unanswered or half-answered questions, if the patient goes home with that, it's going to be a chaos in her mind. So we have to break the news in stages, gently, always truthfully. Of course, one intelligent family member must be told all the facts of the case, and he has to be asked to acknowledge them. We don't want anybody to turn around later on and say, we didn't know all this. And a fully prepared family knows how to support the patient, both mentally and physically, how and when to inform other family members, and to put in order property matters and wills, etc. What about the family? They also need to share their feelings. They need the comfort of sharing their feelings. No one, neither patient or family, should bear this terrible news alone. And it's the mutual support and sharing of anxieties which is going to sustain the family. The problem is sometimes it's difficult for both of them to initiate a conversation with each other. They're trying to protect each other. They don't know how to speak about it. And here, very often, we play an important role. Right there in our office, we can get the conversation going. We can initiate the conversation, and then they can go home and share their feelings in a much easier way. What about the children? Children always sense the truth, however old or young they are. They hear these whispered conversations behind closed doors, and they're terrified. Very often, children tend to relate everything going on to themselves, so they blame themselves. They must be told the truth. How much to tell will depend, of course, on their age and their maturity. Who's going to tell them will depend on the individual family. They must be assured of continued love, and they've got to be told that the attention is away from them for some time. It will come back. But children also should be told the truth in a way which is palatable to them, depending on their age. These things are all very, very important at the end in a family facing a terminal illness. Now, what about us as doctors? We are programmed to believe that we are the curers and the leaders of the team which gives cure. And in this situation, we can't give them a cure. So we also are in a complex position. Nobody's taught us what to do. It's very difficult. It's a blow to our ego to treat a patient without offering a cure. And death in our minds is subconsciously associated with some sort of failure on our part. We may be the object of misplaced anger, as I've said, or unrealistic idealization, and that is even more difficult for us to cope with when we are helpless and we don't know what to do. Our most innocuous comment or a gesture on our part, for example, when we're reading a histopath report and we suddenly start frowning, these things may become very significant in the patient's mind. They're in a very heightened state of sensitivity, and they pick up everything and they give enormous importance to it. So it's very important. Our facial expression, what casual comments we make are very important to the patient. As our conference brochure says, protocols and processes must be in place in any healthcare delivery system, and so too in this difficult situation of dealing with the dying patient. There are certain things, as I said, we mainly rely on our instinct. Sometimes we get through all right and sometimes we don't. So there are certain things we should not do, and there are certain things we should do. Do not make blunt statements just to get it over with or to fulfill your duty, as I've spoken about already. This can be drastic. Don't, on the other hand, keep postponing the issue. And we sometimes do this not because we feel so inadequate talking to the patient about it that we keep prevaricating, using euphemisms, and we don't get down to discussing dying with the patient. Don't ever delegate the task to your junior. This is something horrible. This news has to be given by you. It's not only our duty to tell them, it is our privilege to talk to our patients about their terminal illness. This task must never be delegated to a junior. Never give an overly optimistic prognosis or give false cheer. Never the patients and very often the relatives try to put words into our mouth, but we should never fall into their trap. Never give specific time limits about the length of the span of life. This can have disastrous results. And actually every patient is different, every disease behaves differently in each patient. We don't really know. And if we tell them, you have 2 months to live, then the patient tends to live within that 2 months and she's horrified, she's dreading the 61st day when she's going to die, and she cannot make use of that 2 months that she has, and she may not actually die after that 2 months. So never give specific time limits. Also, don't identify with her to the extent of compromising objectivity. And this is, of course, as we all know, easier said than done, especially when we're dealing with a patient who we've known for years, or we're dealing with a little child, for example, who's dying. But if we are not objective to some extent, we can't do justice to our patient. Never withdraw from the patient, and this is something we see every day in our cancer hospital. And it's not because we want to be cruel to the patient, it's not because we don't care for her, it's because we feel so totally inadequate and we don't know what to do. So what happens in the outpatient, you see this patient who's come in for her palliative care, and all the other doctors are calling in all the other patients in whom they can do something. And this patient is just left there sitting on the bench waiting for somebody to give her attention. And this can really be bad for the patient and relatives. So never, never withdraw from the patient. Never blame her or her family. This is another common everyday occurrence. We're giving you adequate pain relief, you're just complaining about pain. Or to the family, you've brought her in the 4th stage of cervical cancer, what do you think I can do? This is something terrible, it should not be done. They have enough problems without having this horrible guilt complex. In fact, whenever I say, she's in the 3rd stage of a cervical cancer, and the relatives say, but we brought her as soon as she told us. And I encourage them and I reassure them and I say, I know you did. We know that you have done your best for the patient, you are doing your best. You've brought her to the best place. We know all the sacrifices you're making. And then the relatives are so relieved, they're relieved of their guilt, and they are sort of reinforced to look after their patient.